right, so up next, we're honored to have Dr. Laura Appel with us, an esteemed associate professor of health informatics at York University and a leading scientist in XR healthcare interventions. Her work through the VRX lab has garnered international recognition, expanding from aging and dementia care to innovative VR applications for a diverse range of conditions. With influential publications and talks at prestigious institutions, Dr. Appel is a driving force in creating personalized, preventative, and holistic technology solutions in healthcare.
I have a mic. I think I have a body mic. Okay. People can hear me, yes? Yeah. Okay, well, thank you everyone for having me. And I know I'm following up on a number of speakers who have talked about the use of VR in mental health. And my talk is really trying to look at what has been the evolution of virtual reality from new age medicine, using examples from my own research, to seeing what is left, what hurdles do we have to overcome so that it can come of age and be really standard of practice. Seeing as we're right next to Hollywood, I took some inspiration from my slides, so I hope some of you will at least give me some comic relief and laugh at them. I was already introduced. My name is Laura Appel. I'm an associate professor in the Faculty of Health at York University in Canada. I'm also an affiliate scientist at the largest conglomerate of hospitals in Canada, University Health Network. I very much pride myself in doing pragmatic clinical trials. So what was talked about before, a lot of these trials that are done in the lab, essential, necessary, looking at how postdocs can test the fine grains. But I look at really generalizability, feasibility, ecological validity. Can we incorporate this into real clinical practice? I'm also an adjunct researcher at smaller hospitals, dare I say, more willing to implement and innovate. So it's good to have a leg in both these groups. I usually start my talks, which aren't for VR audiences, with a show of hands of who has tried VR before. This is really who's listening to me right now, which is good. Now, keep your hands up because it's not relevant for this audience. Who has seen this maintained in practice? Like, you have gone to your primary care physician and they have, prescribed this kind of medication. Ooh, hands are dropping. I see one lowly soul at the corner. And so really, I'm trying that this talk is meant to be like, how can we get VR past the pilot research phase into standard of care? I wanted to see it in seasons 2 and 3, not past that. We never like season 4. They're usually pretty bad. And so what can we do? What hurdles do we have to overcome? And there are some things, and they've been mentioned in previous talks today, that we've already achieved to date. So what are some signs of maturing? There's this, it wasn't a joke, it was a saying, I think, that Frank Zappa said, that he's like, in order to be a real country, you have to have 3 things. You have to have a national airline, a national beer, I don't think it was military. It was a soccer team. You have to have a football team. Okay, and so the equivalent in healthcare, what are some signs of maturing for XR and virtual reality? We do have a mesh term as of 2018. We have an FDA-approved device. There's also, there was mentions of this before. We have them outside in the booth area. We do have also associations, and as of January, we have our own journal. And so these are really signs that the field is maturing. But what is left? So what is needed in order for us to graduate into the formal healthcare system? And I'm going to list these 4 ideas. We need to overcome and challenge misconceptions about virtual reality's use, both in diverse populations, as well as who can administer the therapy. We need to look, this has been talked about a lot and will continue to be spoken of. Objective measures, what are our outcomes? What are ways we can triangulate findings, our biological endpoints? We need comparators, equal opponents. And I'm not just talking about having control groups with sham VR, but actual, can we compare VR to tablet technology? And what are incremental benefits we can get from the immersiveness that VR provides? And I'll talk a little bit about that. And finally, buy-in. I can tell this audience is unique. But how can we get everyone else to drink some Kool-Aid? Because we all agree that this is great, but we are still a minority. And so with all of this, I'm going to try and bring out aspects of the different research projects that my lab takes to see if we can highlight what we've done and also what problems and challenges we face. And so before I do that, though, I want to take a second to talk about what is unique about mental health. I'm a little bit saved here because some of the previous talks, particularly Dr. Reelfold, kind of covered these issues, but I'll start with what isn't mental health. Mental health is everything. We've seen even with this concept of metasibo spoken about earlier today. Mental health impacts everyone's health in all aspects. And so, this is a unique session, but kind of is addressed in every biological and clinical aspect. There is another point to be raised, and that is that we are in a mental health crisis. So there's a lot of both our aging demographic that is feeling aspects of loneliness and isolation that is very much impacting their well-being and health. And similarly, the younger generation that are exposed to social media and face other issues around depression, anxiety that I see every day in the students in my class, and it's quite saddening because I can tell year from year that it's actually getting worse. And so we do have a mental health crisis, and what is unique about VR, again, not something new that I'm bringing up, but it makes increase in accessibility. So we can provide remote care more easily for those that are not living in urban centers and do not have access to specialized care. We also can make it more affordable. This is another one of the points that Dr. Spiegel raised today. How can we make XR more accessible, more affordable, to do greater good for a larger population? Other aspects of mental health, again, I've mentioned we've had to come up with objective measures. A lot of mental health, both in diagnosing and also in self-report from patients, are subjective measures. And so is there something unique about VR? And yes, there is, that we can start to track new outcomes within these headsets that we're not able to before. We can also introduce new interventions that are more ecologically valid because they represent the real world more than other aspects of therapy that just look at one sense at a time or one aspect of healthcare at a time, where we know that when we are interpreting the world around us that impacts our well-being, it's both our vision, it's our hearing, it's crossing the street, it's us living our actual lives, not things in clinic. What else is unique about mental health? Well, there's a diverse amount of providers, from those that work in acute care to those who are their own providers who can go straight to practice and to individuals. And so we have unique opportunity here to scale through multiple channels and see where is the path of least resistance in order to start and then diffuse this innovation. And so while there are some challenges with the inability perhaps to, compared to other areas of healthcare, target biological endpoints, use standardized, consistent outcome measures, there are also opportunities that we can exploit. Okay, so let's get to some examples here. Firstly, misconceptions. So I'm going to talk about a group of different studies, and this one looks at people living with epilepsy and seizures. That's right, something that is contraindicated on the headset. So I really pride myself in the fact that our lab tries to look at challenging populations. And so what we did here was we wanted to create a virtual reality exposure therapy for people living with epilepsy and anxiety. Exposure therapy is not very new to virtual reality. We've heard talks about it. But in people with epilepsy, this has not yet been done to my knowledge, and is quite unique because, like I had mentioned, there's a contraindication on headsets to use with individuals who have seizures. This is just like a standard warning that they put out without much information behind it, because the photosensitivity, in fact, around this is not warranted. And so I've worked with, give me a second, epileptologists to confirm that there is not really a danger in exposing people to virtual reality. And so what you see here is one of the main research coordinators in my lab, Danielle. She's also in the audience right over here. And she's sitting next to Cameron. Cameron is our 360-degree mannequin, non-binary mannequin, for whom we traveled around to different sites and filmed exposure therapy in hierarchies, graded therapy, to a maximal point of where Cameron, from a first-person point of view, would have a seizure and then recover, and we'd have different reactions. So What are we trying to achieve here? People living with epilepsy often actually describe anxiety as more debilitating than the condition themselves because it prevents them from going outside. They are afraid, sometimes dependent on the person, to be in large groups where it could be embarrassing to have a seizure. They are sometimes afraid to be alone should they need help and no one is there to help them. They often have their driver's license revoked, so they can't use public transportation. They can't drive and they have to use public transportation, and yet they are afraid of the physical dangers of, for example, taking the subway. So they're afraid to go to house parties, they're afraid to go to school, they're afraid to be in work environments. And so this is an ideal population for whom even traveling to get in-person therapy might be difficult, and virtual reality really could provide a solution. So our team, not having, of course, we always have individuals with lived experience on each particular project, but not knowing much about epilepsy and seizure to begin with, collaborated with advocacy groups to send out a survey to try and define different scenarios that often cause anxiety in people with epilepsy. And then we went off, like we did here in a subway, to recreate scenes of increasing anxiety provocation in order to slowly expose people with epilepsy and get them accustomed and habituated as one would with normal CBT and exposure therapy. And so what did we do once we created 3 different scenes. These ended up being the most popular. It was public transportation. We took various subway scenes. One was a house party, interacting in a small group environment. And the last one was a large public scene, and we went to a popular mall during Christmas time. And then we took these different graded exposures, and we had a 2-week protocol. So we first ran a pilot where 5 individuals who both were diagnosed with epilepsy and anxiety would receive a VR headset, and over 2 weeks would have daily therapy sessions. We started off with the first one. It was actually a workshop where they decided which of these 3 scenarios was best suited for their anxiety, together with a therapist. And then daily, they would watch these 360 films in graded exposure, and if their anxiety levels were low enough, they could progress to the next scene, culminating, of course, in them putting the headset on and literally seeing and or feeling like they had a seizure and recovering. And so we had very good results from this pilot study with 5 individuals. Most of the different studies within this protocol have already been published. The last one remains, but we had such success that now we're moving forward with a larger trial in the epilepsy monitoring unit, which is a unit in hospitals where they actually have people with epilepsy come, stay for weeks at a time, and try and induce seizures in order to track them so that they can treat them later. So oftentimes, people are sitting bored, as I hear, in the hospital waiting to get a seizure. And so this is a great opportunity to expose people to, who need it to this kind of therapy. And so we're very excited also. On the same time, I mentioned misconceptions is one thing, and then outcomes is another. And so while it's very hard to get other kind of biophysiological feedback in general when people are in VR, in this case, they're going to be hooked up already to EEG readings for their normal treatment. And so we're going to get very interesting, highly rigorous data from that kind of research. So this is just one example on how you really need to push back a little bit on the general warnings and the misconceptions of who can use VR. Okay, second, and this is somewhat related, so our main body of research at the VR lab are older adults, the senior population, those living with cognitive sensory mobility impairments. Often this means people living with Alzheimer's and dementia. And so again, it begs the question of like, who can use VR? Can it be a very frail population? And my answer to this overwhelmingly is yes. And so I'm just gonna show you guys a quick clip that we have here. Hopefully the volume's up. Doesn't sound like it. Can I turn the volume up? We're not missing the best part. She's just getting the headset fitted, so it's okay. No? Okay, so what I really love about this film, so this patient became incredibly animated after trying VR. If you guys want to read the captions, you can. But what is very special about this, you can see she's incredibly frail. She's not been able to participate in a lot of activation therapy. She's reminiscing about her home and how what she sees reminds her, the nature scene that she sees reminds her. But what I particularly love, and I don't know if you can see right in this scene, it'll move around, is that her recreational therapist is smiling from ear to ear under her mask because she was finally able to connect with this patient. So we have many films like this that just demonstrate that frailty and different levels of cognitive impairment do not prevent someone from being able to enjoy and see the benefits of VR. Okay, that one's pretty obvious there. She's so engrossed in the falls and, okay. She's laughing. It's better with sound. You can take my word for it. Okay, so how do we get to that stage, to have someone so frail, for me to have the confidence to put someone so frail in a VR headset? And it's been many years of work, starting back from, I think it was around 2017, where we did a feasibility trial with 66 older adults on the spectrum of both frailty, physical frailty, and also cognitive frailty. And in this study, it was a feasibility trials at one-time exposure in 4 different sites, from long-term care. There was an acute care, there was a rehabilitation site, and a memory clinic. And we wanted to see, can older adults tolerate the VR headset? We had trends in every way to positive affect and success and their ability to want to. And very importantly, the management at these different clinics were very interested in continuing. And so we had applied and got more grants to look at different areas. So we worked together with Pearly Health Veterans Center, which in Canada is the Veterans Association, similar to the VA, I suppose, here. They have a gem of a little hospital in Ottawa, our capital, and there we looked at targeted versus scheduled sessions to try and manage responsive behaviors. So I believe there were 29 individuals diagnosed with moderate to severe dementia who also had responsive behaviors. And so we wanted to see if we could, either through a general program, provide virtual reality therapy, or at targeted moments when we knew they would be triggered to have an event, if we could preempt that with a VR headset and manage some of their behaviors so that we can minimize, for example, the use of pharmaceuticals, which have a lot of negative side effects. And in that too, we found overwhelming success. Interestingly, it was more for, or I don't know if unexpectedly, it was demonstrated very obviously in physical pain and less for emotional distress. So it was very effective at managing physical pain. Another thing that was interesting here, and I'll touch on it later in the talk, was the buy-in. We always strive to have local researchers, clinicians, or people who are providing care to administer the VR. And there was some challenge here because they had never been faced with this technology before. And while they wanted to do something good for their patients, whom they even, I would say, love and care for, they were hesitant at this moment to put VR headsets on them. And they weren't so familiar with research processes and protocols and how one must do something in the same way in order to prove an outcome. But for those few instances in which they were able to put the VR headset in these triggered moments, they had very good outcomes. And so that was a way to win them over. And so it's very important to always keep in mind, how are we going to involve end users, being the clinicians, the bedside practitioners, in providing this kind of care. At the same time, because of this good trends in managing behaviors, we were able to run a randomized control trial. I believe this is still the largest randomized control trial done in acute care with people who have been diagnosed with dementia. It just got published actually in JAMR, I think a few months ago, and it demonstrated that there were 79 participants, half of whom were randomized to receive virtual reality and the other standard of care while in hospital, to see if we could manage a number of things: reduce pharmaceuticals, falls, length of stay, and various BPSDs, behavioral and psychological symptoms of dementia. And we found statistical significance only in one, but a very important one, in aggressiveness. So in aggressive behaviors, that being verbally, physically aggressive, which also results often in reluctance to receive care. So we did find that the participants that received virtual reality therapy had benefits in this area. Now, of course, The reviewers came back at me saying, this is a very nicely designed study. I said, thank you. They said, where is your comparator? And of course, this is very difficult in virtual reality, and I think was mentioned by Dr. Paul, that it's like, what is our comparator intervention here? We're always like, yes, compared to standard of care, this is better. Standard of care, unfortunately, is not amazing in many instances. So we have to think about how we can introduce something ethically, because I really didn't want to just put a VR headset with no films on for the other group of participants. And so while I was not able to do that in the acute care setting, and I really don't want to pursue that in an acute care setting, a follow-up study we started doing, and here you can see a research coordinator in our lab, Samantha, teaching at-home residents. So there was a collection of studies called VRX at Home, where we looked at providing the same therapy in the home for someone living with dementia, but who is still able to be cared for by their primary caregiver. And so we completed a pilot that has also been published in an IEEE journal. I'm saying this to also demonstrate the diversity of journals that publish this kind of work. So we are a unique group here, from technology all the way through to healthcare. But further to the 10 dyads, the person with dementia and their primary caregiver who participated in the pilot, we also now are completing the full trial, which has over 21 dyads. And so what happens for their study? They are provided with a VR headset and a tablet. The tablet is our comparator. So for 2 weeks, they interact together using the tablet with the same 360 films that they would have seen in the headset. So minus the immersive qualities of the head-mounted display, otherwise somewhat of an equivalent experience. And then they switch over and they try with the headset, and our groups are randomized to start with one versus the other. They're also actually given a picture book to begin with, so we can get a baseline of their communication levels with one another, so we can really determine what is the added advantage of this still somewhat complex technology. And so we did find that there was something unique for those when they were trying VR, and it is this sense of awe that we have been describing. But we have to find a way to quantify that. But that so far is my best indicator for some kind of comparison, because it's still something that seniors, for example, have to learn to use in most cases. They aren't necessarily so familiar with tablets. Post-COVID, that's less of an issue. But it does beg the question, what is the incremental benefit that we are getting from virtual reality over other technological interventions that might deliver some of the benefit? And I'll also mention that, for example, in terms of comparators, similarly with the epilepsy study that we're going to be doing in the monitoring unit, there we are going to be providing a control group with a VR headset that simply doesn't have exposure therapy, but will be playing in VR. Okay, next I'm going to talk about objective measures, which is particularly difficult perhaps in mental health. Like we said, a lot of these measures are subjective, and so I think the best thing to do here is to start in fields where there are already objective measures for some of these outcomes. And so this was a case series that we did. It was actually prompted by a former participant in a previous study who thought that virtual reality would be useful for his wife living with dementia when she was getting specialized dental treatment. In this case, the care series actually had to do with people who have had a stroke. They have a lot of anxiety. They tend to also have worse dental care. They've lost mobility. They don't tend to, in some cases, are unable to clean their teeth and maintain hygiene the way the rest of us are. They also cannot receive the same amount of drugs to reduce anxiety when they're in the clinic, so they go to specialized clinics to get care. And we ran a case series with 2 individuals. I believe one was 60 years old and one was 70 years old. And what is important here is not only, of course, did we collect their subjective measures of pain, but not with this particular headset. We are moving towards this idea of collecting objective measures we can within the headset. So eye movement, pupillometry, aspects that have been related to pain or head gaze in order for it to be a proxy also for anxiety. And so there's a lot of things we can do that are unique to our technology, and I think we should be exploiting those, or at least advertising a little bit more for the medical community what they can gain from these kinds of studies. This case series is also going to be published within the next 2 weeks. So finally, buy-in, and maybe the most important here. These are two trials that are done in another hospital that I work with. The one on the right is a study about using VR in the ICU for extubation purposes, or that was our intent. We interviewed a lot of bedside practitioners before even introducing the concept to the management in the hospital. And the other study has to do with an inpatient mental health unit. And so what do I want to say our learnings were here, because these are clearly two bedside practitioners that are first trialing the technology. And I like to relate this back to the IKEA effect. I don't know if anyone's heard of the IKEA effect before. Has anyone assembled IKEA furniture before? So the idea here is that you tend to like something better when you've worked for it or assembled it than you would have if you had just received it yourself. And so that's really what I think we need to be doing in order to evangelize virtual reality in clinical practice. From the get-go, I mean, it's good practice to involve end users in the design, but I'm talking about very early stages in determining what does success mean for them and what problems are they actually trying to solve. And so with the ICU study, we found actually that practitioners were loving the idea of introducing VR to their ICU unit, but definitely not for short-term extubation. But they themselves were coming up with their own ideas of how to have it implemented, and that's our next stages there. For the mental health inpatient project, what was interesting here, so we start off with nurse champions, 4 individuals, who were tasked with seeing how we might train the rest of the staff to use VR with their patients. And what was important here was that we looked to integrate it into an existing program. So there's something called Safer Wards, which is a relatively widespread program looking at managing conflict in mental health inpatient units. This particular unit had just started this training. So all the staff were getting together. There are different modules in order to manage conflict, as they call it. And one of them, for example, are the talk-down methods or imaginational therapy. And this is where we thought, VR could be another module in this existing training platform. And so we worked together with these nurse champions to try and integrate it into an existing training system that was going on. And so it wasn't like we're just introducing some new tech, but it was built into something that they were going to be getting anyways. And so that had far greater success. Now I'll point out, I don't know if anyone can see, but that is on the individual with the yellow jersey. She has actually a scent cartridge put onto her headset. And I'm just mentioning this because we were testing also the scent of environments matching the environment that she sees in VR and whether this would help impact anxiety and stress levels, which is beyond the scope of this talk, but was quite interesting, especially introducing scent in a no-scent environment. So this just goes to show you what you can do when you have clinicians on board to try and do research. Okay, so I believe I'm nearing the end of the talk, and what do I want to end with? Clearly, we do have progress in the implementation of VR in a research context at least, but also in some practice into healthcare. This scene is from a movie that Greta Gerwig, an older movie of hers that I like better than the Barbie movie, but that's beyond the point here, where it's a coming-of-age story. And it's between a mother who is judgmental and harsh towards her daughter, and her daughter seeks advice from the school advisor, and the school advisor says, well, sometimes maybe paying attention to someone is the same thing as love, because we don't pay attention to the things we don't care about. And to this, I say, people are starting to pay attention. They're starting to pay attention to virtual reality. Clinicians are starting to pay attention. I hear patients who are coming to me starting to pay attention. There is like a growing body of awareness and willingness. And so we shouldn't really lose our opportunity right now. Now is the time to show up and to grow up. And so I think we should seize the moment and hear what we can do to help incorporate VR into mental health and health more broadly. And so on that, I will just end. All of the studies I've mentioned, we are either published or in press. So if you use that QR code, you'll be able to access all the papers. That's our lab website, Prescribing VR, and my email. I'm happy to connect with anyone to talk about VR and health. So thank you very much.
so much. Fantastic.